Hello, my name is Dr. Ashley Parks, and I'll be sharing with you our Chapter 1 lecture today. We'll be talking through the value proposition in healthcare, specifically the management challenge of delivering value, and what we as health services administrators have to consider when we're delivering value or facilitating the delivering of value from a clinical perspective, from a quality perspective, from an economic perspective within the health system. So thanks for joining me. So, the purpose of this lecture is really to focus on our definition of value and how we attain value. And so, we'll start out with that definition. The concept of value is providing a quality service or product at the same or lower cost relative to other producers. And we often think of that as very similar to efficiency, which is doing a lot with a little, right? The ratio of inputs to outputs. Here, we want to provide quality services, we want to provide quality experience, and do so in an economical manner. And so we do a lot of things to increase value in healthcare, and we'll be talking through those over the next several weeks. We assemble and clarify alliances. We build teams, we bring them together, we agree on roles, we develop infrastructure, processes, and buildings, and ways of doing things that serve our patients well. We balance our global commitments and our local commitments. So maybe you have services that are rendered in a local healthcare facility, but you're also delivering services via telehealth, maybe to a greater area within your state. Or maybe you have a global outreach program where people come from other countries to receive services. And then, of course, we use our managerial skills to manage people, finances, clinical quality to deliver value. Now, the fundamental challenge of delivering value is really big. When I say you're going to go out into the community and you are going to deliver value, okay, well, that means different things for providers, meaning physicians, NPs, PAs, respiratory therapists, right? Health services organizations like hospitals and skilled nursing facilities and residential facilities. That's different than what a supplier would deliver. If you're a supplier of N95 masks or certain products, it's very different in how you deliver value. Same thing if you're an insurer or an insurance company, or what we call a payer or a health plan. And so we want to deliver value, and we do it in different ways again. But really, we're going to think about that iron triangle of healthcare when we talk about delivering value: improving quality, improving access, reducing costs. That's our iron triangle. Now, when we think about that challenge, we know that healthcare costs are rising. They've risen steadily over time. And we know that the major factors that contribute to that, there are many, but we know two of them are an increasing use of technology in healthcare. We know technology can be very expensive. And we know our insurance system and the third-party payer system is also very expensive. The way that we're giving money every month to a third party, an insurance company that then pays, but they also need to approve, in some cases, authorize certain services. That all involves a lot of administration and coordination, and that costs money. And so those are part of the rising costs. We also have these supply side costs. In healthcare, and what I mean by that is in healthcare, we don't necessarily always know what we're paying. And we should on the hospital side because of CMS price transparency, which is a totally different discussion, and price transparency laws. But in general, especially if you're going to a physician's office, or if, let's say, you're a busy mom and you're taking your kids to an emergency room, you don't know necessarily how much that's going to cost in totality for the physician, the ER, the radiologist who read the film for the broken arm, right? Though those costs are really shrouded in imperfect information. We don't know. Now, if you take your kids out to eat, you know it's $12.99 for the hamburger meal. Healthcare is a little bit different. So we have that imperfect information. And then, of course, we also have this pressure on the provider side in that there's this oftentimes this feeling as though we have to be super sure nothing's wrong. We call that defensive medicine, but where we're running extra tests, right? And that can increase costs. but also maybe we're not getting preventive services, and instead we're going to an acute care hospital, or our care is not being coordinated, so it's more expensive in the end. These are all parts of those rising costs. And so that's part of what we're competing with, or competing against when we're trying to deliver value. Now, when we talk about supply side drivers, right, these are elements that affect the supply of healthcare, right? And the demand side drivers affect the way that we can uptake healthcare and use healthcare services. And so there's a lot on both sides, a lot of I don't want to say barriers, but there's a lot of issues, a lot of struggles. For example, one of the things listed is moral hazard. You may have learned about moral hazard in one of your other classes, but moral hazard is the idea that if someone is older or fundamentally just more sick, they have more healthcare needs, they are more likely to sign up for insurance. And so the idea that if you offer a service like health insurance, the people who are going to participate in it are those that are ill. Those are the folks that are going to want to sign up for your plan right away. Now, there's another side of moral hazard that deals with service utilization. If I have insurance, right? And what I really was just describing was adverse selection, the idea that I want to have it because I have this adverse situation. Once I have it, the other side of that equation, moral hazard, kicks in where I want to use it. The example that I give for moral hazard, that's a demand side driver, is going out to eat. If I take all of you out to eat and we go out for a steak dinner, and I say, do you want to order the tomahawk steak, right? The giant steak. Well, that depends on who's paying. And that's what moral hazard is all about. If you feel that someone else may be footing the bill, economics say that individuals are more likely to utilize services that they personally are not paying for. And so that is a driver in health services. If I already have met my deductible in my health plan and it's not a lot of expense for me to get a procedure or go see another doctor, I'm more likely to do that because my insurance is paying, not me. Just like you may be more likely to order the tomahawk steak if someone else is paying, if App State is paying and not you. That's the concept of moral hazard. So there's a lot of factors here, some of which you probably already learned that concept, but some of which you've learned about before, that lead to rising healthcare costs. And one of those factors is that third-party payer system, where if someone is insured, they're more likely to order the steak in more ways than one, right? They're also not worried about heart disease, maybe. So we have a lot of challenges exacerbating the value challenge. So challenges within challenges. When we think about trying to meet this growing demand for health services with finite resources, we only have so many primary care providers, so many nurses, so many hospital beds, and we saw that during COVID. We see that we're trying to address chronic care, things like heart disease and cancer, lung disease, with acute resources, hospitals, when really there's a lot we could do to prevent certain conditions and or manage them. Think about diabetes. If you end up in the hospital due to complications from diabetes, there may have been a lot of other things we could have done as a health system or you as an individual to prevent that from happening. And so that's a challenge. We're trying to build these population health models where we're looking at risks and we're screening individuals and we're responding to risk early to prevent these hospitalizations, but it's new and it's not perfect. We're also really limited in healthcare in that people's information is private. So it's not like we can share everyone who's been to a facility and try to problem solve and prevent issues in the future. Their personal information is private. Their health behavior information is private. Their information, of course, in the hospital is protected by HIPAA or in a facility, right? So we have to keep in mind that that's a limiting factor when everything is also shrouded in privacy. While that's a good thing individually, sometimes it limits our ability to use the data to bring about change. We also have to think about, again, technological advances, technology really raising costs, and the challenges that we face on the public health, population health side with trying to promote healthy behaviors, promote wellness. Now, these challenges are global. These are concerns that you can see in the literature are common in the United States, but also your textbook has decided to draw some real strong comparisons between healthcare in the United States and challenges in India and China as global examples. And so when we think about having a high number of specialists, but a low number of generalists or family practice physicians, that's a problem that exists across these countries. When we think about concern with high costs of technology, that's a problem that exists in all these spaces. All right. We also have to be real about where we in the United States have limitations and challenges that aren't the same as other countries. For example, we are spending per capita, per person, a lot more money than is spent in other countries. In many cases, 2, 3, 4, 5 times what other countries are spending per person in order to offer health services. I recently saw a video online and it was teasing, but it said, goodness, universal care is so complicated, so difficult to do that only 32 out of 33 of the most developed nations have figured it out, right? We're the 33rd that hasn't, right? Our use of private health insurance is very different in the United States compared to other countries. The percentage of money that we're spending on pharmaceuticals, again, because we're focusing on treatment versus prevention, is also a lot higher. And we have, of course, different policy, different government functions, different governance. So these are challenges that where we diverge from the global comparisons. Now, we lack any single national health insurance program, right? Instead, we have this fully developed value chain. We have suppliers and consumers and a lot of different stakeholders coming together that all have different interests, different perspectives, and very entrenched positions. And so, if we were, let's say, to propose a universal health system, something like a national health insurance or a national health service, if we were to try to do that, we have a lot of individuals, health insurance companies, the American Hospital Association, the American Medical Association, that all have their own vested economic interest in keeping their flow of funds and their place in our system as it is now. And I talk about that quite a bit, so we won't spend time there today, but it's very important to realize it's complex. And this is an image of that, so you can see we've got regulators, we've got suppliers that are all very probably happy with the money that they're making in pharma and biotech, maybe not leaning towards or comfortable with supporting a leaner model of a national health system. Of course, we've got the government and our current government programs, a lot of bureaucracy around that, but also a lot of Americans work for those programs, right? Medicare, Medicaid. Even I work as a non-compensated research faculty for the VA as part of my appointment here at App State. So a lot of us are involved with those agencies and supporting what they currently do. And then, of course, we have public health agencies at the bottom. But you can see this is a very well-established value chain, right? We have a way of doing things in the U.S. health system. And so changing that it would take a while. We'll leave it there. Now, it's difficult for a lot of different reasons, right? A lot of regulation, a lot of policies that specify why we do things the way we do, and almost all of that would have to change. Many laws would have to be thrown out, rewritten, overwritten in order to move forward to a simpler system or a more unified system. Consumerism. We like getting what we want. We want our telehealth appointment quickly. We want access to care. And so the idea that we're comfortable with our doctor, maybe we wouldn't want to sign up for a government plan that meant we couldn't go see our doctor down the street. And so we have to realize that. We also have to realize groups like the American Medical Association heavily influence health policy. We have to realize there is money and incentive behind competition, and that a lot of large health systems own certain areas and have reduced the competition, which has increased their revenue and market share. A lot of challenges, right? When we think about the way hospital care is offered, right, and how that is the biggest income stream, not in percentage of the total health system, but when we think about how much a hospital visit is and how if folks were to be more healthy, how that would impact revenue, even if it is good from a population health perspective. Healthcare delivery is largely local, which adds to complexities. Every hospital, every healthcare manager would have to change the way that they see the world and the way that they do their job if we change the health system. We have a lack of valid data about quality and cost and all those interrelationships across the nation. We have bits and pieces, but drawing that all together in a compelling reason is a real challenge in a compelling manner. And then, of course, outside business practices have failed. And what I mean by that is we've had groups that have come in. Haven is a great example of that. Berkshire Hathaway, Chase, and Amazon formed a healthcare group. It was like a think tank that came in and said they were going to bring in outside business practices to fix healthcare, and they disbanded within a few years. And so we haven't been successful with applying those things here. Now, there are some business practices that have been adopted by hospitals in order to deliver value. A lot of different approaches, and we'll be discussing each of these throughout the course. So I could spend 20 minutes on this slide just going into detail, but we will talk about what a Theory Z manager is. We'll talk about quality improvement in our week on quality improvement, organizational learning. But there's a lot of different processes we've adopted to be better, faster, stronger, to deliver better healthcare within our organization by organization viewpoint in what is a very fractured system, as you've seen so far. Now, when we think about that systemic view, that systems thinking view of healthcare, which is so important, we have to realize that health outcomes are driven by our national infrastructure, not just our healthcare infrastructure, access to healthy food and water and safe spaces and walkability, all these different factors. And we also have to realize that if we want to make change, we have to work together. So there's value in working in this interdependent system, in partnering across. So if we can partner with a hospital with many other hospitals in order to bargain and get better pricing from suppliers, we'll deliver more value or be more efficient in delivering value to our patients, spend less money on supplies. So we can conquer those small pieces within this very large system. But we have to realize that innovation requires a lot of change and the ability to not just change once, but iterative change over and over again. And then also realize that organizations consolidate into systems to be efficient. And so we have these really large health systems that have come together. They've pooled their bargaining power and their resources, which is wonderful in many cases, but also that can reduce competition. That can impact the health services available in an area. So a lot of different things we have to think about when we think about that big system viewpoint of healthcare. Now, this is an example of the U.S. health system, but this viewpoint's a little bit different than what we saw earlier with the organization by organization type. This is looking at the healthcare system and how health policy is made and how we deal with and understand our outcomes of our health system. And so we've got these background factors, things like the United States cultural context. Think about the way we treat one another as American citizens, as United States citizens. Think about how we treat residents of the U.S. that aren't citizens. Think about how we offer or don't offer certain services to certain groups, right? That cultural context. Think about the individualism that's such a big part of the United States, right? So we've got these factors here. We've got social networks, and then, of course, all those social determinants of health are in this first column. Access to healthy food and education and housing, lifestyle factors, health behavior, socioeconomic status, jobs, and education go together, right? All of that is part of what influences who has access to health services. And then we've got all these policy levers, different initiatives related to how we finance and pay for health services, how we organize hospitals and health plans. There's so much that already exists from a law perspective and that dictates our health system. And then we've got these outcomes. Things like, was I readmitted to the hospital? Things like, could I get in to see a doctor? Access and quality and efficiency of care that then lead to the ultimate ends are long-term impact measures looking at health status of our population, looking at the affordability of care for our entire nation, looking at the percent of GDP spent on healthcare. So this is just a snapshot view of that health system. Now, we in this course are going to cover a lot of different theories. With chapter 1, you'll notice that they introduce the idea of conceptual maps. The idea, and we've already seen a few, that if we put concepts into a grid or on a map with interrelationships, this is a conceptual map, for example, it helps us think through, prioritize issues, and understand interrelationships. And you can see already how much bureaucracy, how much governance, but also time and energy, maybe a little waste, goes into the management of our health system. And I tease when I say maybe a little waste, right? And so understanding that is really important if we want to make change, because we have to be real about where our gaps and issues are. Now, Weber is an example of a management scientist that talked about pushing systems to be capable of the highest level of efficiency. And we can do that if we define at what level we're working. If you work in a hospital or an outpatient physician office or a health plan, you can help that organization operate to a high level of efficiency. But how do we pull together and help the health system deliver more value for less? That's the challenge. Now, one of the main management scientists that we talk about a lot in health services administration courses is Frederick Taylor. And he emphasized this control element of bureaucracy, how everything is controlled, how there are steps and processes and ways of doing things. People who lead, people who follow. Not that it has to be perfectly discrete like that, but the idea of a hierarchy and how that influences how we make decisions, how we get things done, right? And organizational culture. And so when we think about classic healthcare administration, if we go back 50, 60 years and we think about having a CEO, this unity of command and direction, knowing what we're doing from one single source, the idea that an individual's perspective is subordinate to the general interest of a group, right? To the idea of what's best for the organization or the population, and that we centralize authority. Now, not all organizations operate like that, but that's kind of a classical, traditional hierarchical viewpoint. And we'll dive into a lot of different other viewpoints on administration and organization. We'll talk about programmatic organizations. We'll talk about different ways to organize your work teams. So we'll get there. All right. So we also have the Human Relations School when we think about management theory and people and their perspectives. And a lot of people study these theories that look at the use of and the primacy or the primary function of group structures and individual behavior. So the idea that it's all about people and the way people interact. Then we've got the contingency theory of leadership, and this looks at the effectiveness of specific management approaches depending on the situation. Basically saying that it matters where you're at, it matters the situation you're in. And so we can't use one theory, one way of leadership, one way of management. We have to constantly adapt based on the situation we're in. And that's followed by another school or another segment of management scientists who develop theories. And that's our decision-making school. We're going to look at different theories around decision-making and all the work that has to be done by middle managers to make effective decisions. And that can be very frustrating for some of us early and mid in our career, having to make effective decisions in a controlled environment, realizing that we're pleasing those we're working for, trying to do the right thing, trying to be good stewards of their resources, and trying to manage the expectations and needs of our employees in an ethical manner. Another piece that we're going to talk about throughout this course is the idea of institutional theory. Realizing that organizations or organisms, they exist in a space that we work with other people and we together form almost like an organism, a subculture, if you will, a group of people trying to get something done. And so when we think about changes that we want to see in the health system, that's constantly going to be through the lens of who we are as an organization, what our organization's needs are. So institutional theory really focuses on what is good for me and my organization and understanding how to advocate for our patients and our constituents, but also you're always going to have that lens of the needs of the institution, right? And so we have to think about that. And it limits the degree of rationality that we have because we're not part of another organization. We're part of our organization. It's our viewpoint. All right. Now, a lot of times we're going to try to separate ourselves from that institutional viewpoint and say, okay, what's good for the system? How would I feel if I was this health insurance company or this supplier? We try to think about multiple perspectives and then an overall system perspective. And there's a lot of theories that look at how organizations come together, how they negotiate, how they work together effectively, and the importance of being able to do both. You've heard of the term ambidextrous, meaning you can write with both your right and your left hand or do things with both hands. I happen to be ambidextrous. They're talking about this emphasis of the idea that you're improving your organization, your performance, your efficiency, but you're also trying to impact the system as a whole, the environment, the technology being used, your peers, your colleagues, all of it together. And then, of course, we have the strategic management perspective. We have several chapters on this that deals with the idea of your structure in your organization being set by your mission, vision, values, goals, your strategies, And then the idea that you are constantly competing and you're being strategic, making moves, maybe strategic alliances coming together, and that you have distinct capabilities, distinct resources that you're leveraging. You are a Walmart, you are a Kohl's. I like to use retail analogies because when we think about healthcare, are you the Walmart of hospitals? Right? Or are you the couture bridal store of hospitals? What is your niche? What patient population are you serving and how? So we think about that. We also think about relational capabilities. So do we want to expand for a hospital? Do we want to integrate vertically or horizontally? Do we want to buy another hospital? Do we want to buy a skilled nursing facility? Do we stay within our line of business? Right? Or do we integrate vertically and expand into many other lines of business? And so that's what strategic management is all about, making those big decisions. Now, what's really important is that we recognize this idea of organizational ecology. And I'm a big fan of organizational ecology. I use the term organizational culture a lot, but the idea that anytime we're trying to make decisions, lead teams, we need to understand our environment. What we've cultivated, not just the policy environment and what impacts our organization, but the environment within our organization too. So who is part of our team? How do we promote, retain, choose who we staff, how our teams are formed? The idea of creating our own little world, our own little ecosystem within our organization, which dovetails really nicely with the social network perspective that we'll talk about, that looks at formal and informal relationships. How do you get work done? Are you part of a team that works together all day, every day? Are you part of a bunch of informal teams that work on various projects? And we'll talk about different structures, different types of teams, different types of projects. We'll talk about the permanence of those things versus having temporary projects versus long-term initiatives. But the idea that we're all working together, influencing one another, and that those influences can create different future realities based on that social network perspective. And so we'll dive into that. Again, systems perspectives are a big piece of this. The idea that we want to integrate our services, we want to bring as much as we can to the patient from us without sending them elsewhere. That is a conceptual model of system integration. That's one system perspective. We have another system perspective of how do we embed patients and clinicians into an environment that allows them to receive all the services that they need, but also maybe closer to home, right? So the idea of trying to create these microsystems. So that will be interesting. This is an example of a systems map. You'll see that this is a famous map called the CDC Health Run. And this one looks at the impact of all of the various, not all, but a pretty expansive list of different determinants of health. Things like behavioral risks, socioeconomic disadvantage, right? We've grouped a lot in there. The idea that primary care physicians and reimbursement rates and the complexity of insurance, all these things impact our health. And so this is a viewpoint of that, trying to incorporate a couple of the different theories that we just barely alluded to, but we will discuss in the course together. Now, when I think about organizational theory, I'm going to be quoting over the next several weeks individuals from different backgrounds. We're going to talk about Frederick Taylor. We're going to talk about Goddard. We're going to talk about the father of modern management. We're going to talk about all these different perspectives. What's really important is that we as leaders try to think about what we're trying to accomplish for the system and try to think about complementary rather than competing approaches. Now, I'm not telling you that this class doesn't have business elements, that we're not going to talk about competitive advantage and competing, but the idea that if we want to do good in our health system, we want to support the health of the system as a whole, and really realize that that viewpoint can absolutely apply to the way that hospitals and physicians collaborate and how we do that in the future. All right. There are a lot of different topics in this course. So this lecture just barely gave you an idea of where we're headed. The fact that we're going to look at various theories and approaches to improving the way we deliver value in healthcare, to understanding the way that organizations function and processes are developed. These are the main chapters we'll be covering. In this course, we do not cover chapter 13 or 14. We don't talk specifically about consumerism, although that's a theme I talk about, I think, almost every week. our desire for health services. And we don't dive into managing information technology in this particular course. But we are going to talk about organizational design. We're going to talk about motivating people and building teams and communicating vision and managing conflict, right? So we'll start there. Then we're going to spend quite a bit of time on organizational learning, how organizations learn and implement new things, and how they improve their quality. Then we'll have a week where we focus on competitive advantage and how we strategically lead, strategic advantage, and strategic management. We'll talk about managing strategic alliances, building teams through mergers and acquisitions or joint ventures, bringing together skills and resources, financial resources, even from different organizations in order to achieve a greater good in our community, in order to build something bigger together. We'll also talk about healthcare policy and regulation, and we'll talk about globalization quite a bit. And so that's kind of our roadmap for the rest of the course. I hope that you find it interesting. Today's lecture, again, was just a high-level introduction, but as we go into future lectures, we'll really be digging into bits and pieces. This is one set of questions, and this isn't your discussion for this week or a homework assignment or anything, but this is something I want you to think about. Unions. The idea of collective bargaining or unions, the idea that you have team members who are part of a union that can then advocate for them. That is a huge challenge in healthcare and strategic management. Unions aren't legal everywhere, right? I used to work in California. Northern California has a huge union presence. Southern California, not so much. But they are very popular amongst professionals such as nurses. And I'm curious, based on what we've talked about so far, what form of management would you use to deal with your employees wanting to come together, advocate for themselves, but bring in a third party to do that, bring in a union? And I'm not trying to be pro or anti-union. They serve different purposes in different places. But if you're the manager and they're bringing in a union, that is something that you should be concerned about. That is something that you need to manage and deal with. So I'm curious, out of all the approaches that you see in the textbook as you go through and you read chapter 1 and start reading the other chapters, what you would do. So I want you to think on that. Also realizing that in other countries, there has been huge unionization. And so examples are given in Germany and China, huge unionization where it's not necessarily the workers' rights being representative, but sometimes this agency, this organization is the middleman. And so if you were dealing with that, how would you? Versus in question 3, you'll notice I'm asking if you were head of a nursing union, right? What management approaches should a union use? And we'll talk a little bit about negotiation and conflict management later. So we're going to come back to this. This should feel, I don't want to say foreign because you may have taken classes in some of these subject matters, but this should feel different, these questions. So we're going to come back to them towards the end of the semester, circle back to the idea of how you would effectively manage as someone working as a leader in an environment where a union rise is occurring, right? Where a union is being brought in versus how would you lead a union? And hopefully in 8 weeks or so, you will have